Okay, so our next speaker is Dr. Kennedy Kipkoech. Kennedy has now presented I don't know how many sessions in INSHU. That's amazing. So Kennedy is a senior research associate at the University of Bristol. Thank you, Kennedy.
Thank you to the co-chairs for having us. As a research group at the University of Bristol, I think we are immensely grateful to be given this opportunity to present. This afternoon, I'm presenting some of the work that we've done, and the work that we've done on modeling the interventions for HIV and hepatitis C among people who inject drug in South Africa. But firstly, I will be presenting some modeling work for HIV interventions in Pretoria, which is a setting that is a high HIV prevalence setting. And then I will briefly give an update of a national co-infection HIV hepatitis C co-infection model that we are currently developing. And this is work that have been done in collaboration with so many people, including Andrew Scheiber, who is sitting here. Thank you. Those are my acknowledgements. As I've mentioned, this is work that have been done immensely by so many people, and I really acknowledge them, including data that we've received from stakeholders, including data that were presented here. And so we also do acknowledge various agencies that have given us access to data, including TB, HIV Care, CDC, Sakendu, HSRC, and so many other people here in South Africa. Thank you. So I don't think I really need to give any other background, because the people who have spoken here have really made an amazing background in terms of indicating why this work is important. So I'll just say, the data that has been shown here says that, despite progress that has been done in programs, programming is sparse and in early states of implementation. And so what we are trying to look into is, in terms of the aims, are we able to estimate the impact of existing interventions for people who are injecting drugs? And we started looking at that in Pretoria, which is a high incidence setting. What we focused on was to look into traditional interventions, and this includes ART, opioid agonist therapy, and needle and syringe programs. And then we looked into estimating the potential impact of both the existing interventions as well as new interventions, not necessarily new, they've been there in other settings. These include LADP as well as LDSS, that is a work that is being funded by UNAID in a number of countries, a work that we are supporting. And so we are currently doing that as an objective. So I'll present the approach that we've done this work in terms of the model structure. We try to develop a model that mimics most of the data that has been presented here in terms of looking into the demographics, what's the data saying in terms of risk behaviors or risk factors, having HIV infection and stages of treatment, and ensuring that we have in our model harm reduction interventions, ART, and other interventions as are implemented in the country. In terms of the approach on model parameterization, we've been really grateful as a team to have received by behavioral surveys from stakeholders here in the country, received national household surveys. Thanks a lot to HSRC for availing that to us. And what we do is we use that information of data and look into the differences in risk, differences in prevalence from the different surveys, and we try to put that into a mathematical model that will be able to try to fit into that data and reproduce what we are seeing from empirical data. So that's what we do when we mention about data parameterization and calibration from a modeling perspective. In terms of the model analysis, generate results, we rather estimated the past and future impact of scaling up existing interventions, and so those are OAT, ART, and NSP over 2023 to 2030. Just as a baseline, for Pretoria, ART coverage that we estimated from the analysis that we did from the model is 39 ART coverage, 75 NSP coverage, and low OAT coverage, as was mentioned by Joel a while ago. And we tried to look at some of the scale-up scenarios. And this is some of the work that we've done previously and presented in 2023 INSEU. And we've also tried to see what would be the impact of combining all these interventions, ART and harm reduction. When we looked at how the model fits, what you see in these charts, they look busy. You see what we've done in terms of fitting the model to existing data. So those points with some error bars in the first chart, and I think a few of those charts, are the existing data that we have. We have the population sizes, HIV prevalence, ART, OAT, and NSP. And we try to make the model to fit into these data points. And why I can just summarize that busy slide is to say that overall, the model fits well to the data. We then use that information from the fitted model to see what has been the historical impact. And again, I apologize, this is a busy slide that tries to show the past impact of interventions for ART, which we assume started in 2001. And again, that's an assumption based on when the ART program was rolled in the country, which may not necessarily coincide with when ART was rolled for people who inject drugs. What I can say is there's a green line that shows no interventions. If there were no intervention, then the prevalence would be higher among the different populations groups. And so we are showing a chart for all populations group for male and for female who inject drugs. So if we never had any intervention, that prevalence could have been almost 10% higher. And so it shows that impact has been high, particularly due to NSP, which currently has a high impact, high coverage. Moderate impact that has been seen through the scale-up of ART, and the least impact is on OAT, which is still at baby steps in terms of the coverage. In terms of percentage infections averted, we've shown that all these combined interventions over the years that have been rolled over, they've been able to avert between 8.2 to 29.4% infections over the years. When you look at past interventions in terms of infections averted, so overall, that's about 16%. This is another busy slide that shows what is the impact for male people who inject drugs, for female, and overall for both populations combined. The green shading or the green color shows the impact for all the interventions. Then NSP, OAT, and ART in that order, and it shows that the programs currently they have some impact. But however, I must mention that these programs are still having low coverage, and so the impact could have even been greater if coverages could be higher. So in conclusion, I'll say that historically interventions have had substantial impact to date with higher NSP impact, but ART and OAT have both moderate and low impact respectively. We've shown previously, though we've not updated for this work, that ART and harm reduction in combination will likely even have more impact if they are scaled up to the 95 coverages. And so that's a piece of work that's ongoing. I'd mentioned that we are currently modeling the impact and cost effectiveness of combined HIV prevention interventions, and this is a national model that's funded by UNITAID. We are trying to develop a dynamic model for HIV and HCV transmission in cities or districts, about 12 districts that the programs are ongoing. In terms of where we are as a progress, just currently, we've just finished what I'll say is calibration of the model. So far, we are impressed with that work because we can see that the model is fitting well to the existing level of data. And again, massive thank you to the people who've availed that data for us. In terms of the next step, we are working on starting to generate results from this fitted work. And we hope at some point we'll be able to share this work with other stakeholders. With that, I wish to thank you all for listening.